Morning, guys, or afternoon, guys, I guess. Morning, afternoons, and we'll get this talk going. But actually, I was wanting to get this talk up. I think pretty much, number one, I'm not quite sure what your particular interests are, but in terms of particular airway issues, it would help me to understand from what your questions are, and I can structure the talk pretty much anyway from around that. So maybe could I just have a show of hands in terms of, do people anywhere, is there any people with kids who have issues with laryngomalacia, tracheomalacia, vocal cord paralysis after PDA locations and PDA issues? Yeah. So if we were going to start with one of those three, which one should we start with? How about people ask a couple of questions, and I can frame it like that while we get the slides going. You guys have issues with vocal cord issues in PDA. Do you have a particular issue that you're concerned about?
No, we didn't have any issues. We just experienced it, and it wasn't severed, but it was still strained, and that's actually how we found out. I'm sorry. So when he had his PDA, one of the symptoms that we noticed was he would start crying. You could see him crying, but you couldn't hear him crying. And that was a result of his aorta being severely inflamed, and I think putting a strain on his vocal cord, if you will. But he recovered over time. It took a few weeks after the surgical procedure, but he recovered over time. Is that typical?
Yeah, I just would say so. So that the nerve that moves your vocal cord is called your recurrent laryngeal nerve, right? And your recurrent laryngeal nerve, like the word describes, goes down from your brainstem, goes down through around your heart, and comes back up to your vocal cords. That's why it's recurrent, because it's seen twice in that area. And whether your heart is large, or particular chambers are large, or whether or not for those who have PDAs and where they're ligated up to 20% of the time, that nerve can be bruised or damaged. And what you're describing is the really very common theme, I suppose, which is that for the first thought is your children can be hoarse. The second symptom is your children can have issues with swallowing, and they can aspirate. And where we have our wonderful speech pathology colleagues with whom we work really carefully in terms of this, the primary intervention is really time, conservative management, in terms of trying to not intervene. And then if there are issues with regards to intervening, then there are different things we can do, such as injections and even nerve reinnervations. Does that make sense? Yeah. Other questions? Go ahead. I think I'd rather focus this if we can, and if there are pictures, I can show pictures, or we can do questions however you want.
Our daughter, Faith, chokes on almost everything she eats. We would always say that it was because she's eating too fast. We just did an endoscopy and said that her esophagus common with this altitude. That the esophagus is so inflamed.
Your daughter is having trouble choking. Have they done something called a swallow study besides the endoscopy? Do you know? And what is the endoscopy?
They did the swallow study. They said everything was fine.
What's that?
She has multiple strokes in her life.
Got it. I think that one of the things, and Leo was there too, in terms of one of the things we divide these things into is thank you so much. So good. If there's a functional issue in terms of what you're talking about, is there a pinhole airway, so an anatomic blockage, right, versus a neuromuscular issue where it's not, it looks like it's blocked when it's not acting functionally, it's not moving. And those are the wonderful manometries. I don't know if Leo was here when we did it, in terms of doing these esophageal manometries can be super helpful. And the last issue with the multiple strokes is to see, are the vocal cords moving? Just like you have the PDAs that are the recurrent nerve, you can have issues with strokes. You can also have issues in terms of your child can be aspirating because of that as well. So it's really a comprehensive evaluation to see, not just, when you're talking about the endoscopy is just telling you what the anatomy looks like when your child is asleep. It's not telling you what your child is looking like when your child is swallowing. So, one of the key issues here is, and this is true for a child's having difficulty breathing or swallowing, we want to try to recapitulate what is happening when the problem is happening. And that's where the difference with the exams can be had. Does that make sense?
So the size of the esophagus is different when you're sleeping than it is when you're actually sitting up and.
Well, I guess, so the primary issue is swallowing. Is that what you're describing?
She does sometimes tend to, I guess, choke, or maybe the food kind of is slow to go down. We do give her some water, and she tends to be okay after that. It does go down, or she'll throw up. Although that's been lesser, that's been happening less. She's been able to just swallow it and slowly goes down. But I guess the endoscopy shows that her esophagus is at its lowest point where he could get into with the little camera was at 1 millimeter.
Which one?
1 millimeter. So, but she was under anesthesia. I believe she was laying down. So does that affect the size of the esophagus?
Yeah, I think it probably merits a little discussion afterwards as well. But I would just say, in terms of what things look like during endoscopy, they're not exactly always the same when you're lying up, so sitting up, or lying down, but also when you're awake versus asleep. And the three ways that we look at it are both endoscopy as well as swallow studies, and the video swallow studies done by the speech path folks, as well as the manometry aspect of it, which I don't know if it's been done or not, to try to get a sense of, is that a muscular problem?
She had the swallow done last year, May, in 2018, and that was perfectly fine. In October, she had the G-tube placed, and there was no mention of endoscopy, but they went into the belly button.
Right.
And we hadn't had an endoscopy done since, I want to say 2016 or 2015, up until just the one that we did 3 weeks ago, which showed the difference in, I guess, diameter or whatever.
It's smooth muscle, right? Or is it-
So this is the first kid that I know that they read it as a esophageal stricture. So they think that there is a narrowing, but she also has a spinal cord injury from a very complicated PDA surgery at Ivanovic.
Yeah.
So I think
It's
it's really important question, but I think that you guys have a multiple hit. So swallowing coordination from strokes, you may have the vascular issue that we're talking about, and the smooth muscle in the esophagus may be doing similar stuff that what we see in the vessels. Very difficult for us to, we haven't looked at the pictures and I don't have any other.
The only quiet thought is if it's a very discrete segment, and depending where it is in the esophagus, in terms of if it's up top or the top, middle, or lower, we are, and this is where manometry can be helpful to see if it's small. The question: is there a role for dilation? Is there a role for muscle? Is there a role for Botox to weaken that muscle so it can? And is there a role for surgical for the top part of your esophagus? It's called your pharyngeus or your upper esophageal sphincter. And there are times when we do myotomies, which are little incisions in the muscle to weaken it. So it's super important to know where that exactly where that is in terms of in terms of not just what the surgeon's eye looks like, but in terms of where the narrowing is, and that's where manometry would be very, very helpful.
Yeah, what Dr. Rodriguez was talking about, that thing that measures pressure, maybe the next.
Yeah. Other questions? Maybe what I would just do is just thanks since Ryan was so happy to put this on. Just to say that when we hear, let's see if it's playing. Can you guys hear that? So when we listen to the adapt versus when we listen to can you guys hear that? When we spend a lot of time looking at kids, and we look and we listen. I think this is where Ryan goes to try to get. So when we see kids, we spend a lot of time thinking about where they're having trouble breathing. Are they having trouble breathing when they're breathing in, when they're breathing out, or both? And it's very, localizing when their breathing issue is happening will give us a lot of information in terms of where that problem is. We can pretty much pinhole that if you're having if your child has a problem breathing in, they're having a problem above their vocal cords. If your child has trouble breathing out, they're having a trouble below their vocal cords. And if you're having trouble breathing in and out, it's somewhere around your area of your vocal cords. So with all the, we've got a lot of scopes and we've got a lot of different ways of looking at things, and we're looking at endoscopies and issues, but history and physical still is the name of the game in terms of really getting a sense. And often parents will know in their own situation what exactly they can localize the problem for us by just letting us know where that is. And just, I think that just a lot of times we say to ourselves, this word laryngomalacia and tracheomalacia get thrown around a lot, and just so you guys, malacia means floppiness, laryngo means the area around your vocal cords, trachea is the pipe between your vocal cords and your airway. When we look at this is your looking bird's eye view down, this is a laser pointer. Yeah. Here we're looking right here. When the child's mouth is here, their feet is on the other end of on the other part of the screen right here. We're looking at the child's airway right here. Normally, when you look at a child's airway, you'll see these red white bands here, which are your vocal cords. You don't see much here. The food pipe is here where the bubbles are. And laryngomalacia just means when you're breathing in and when you're breathing out, you don't see your vocal cords very much because the structures over the airway, the muscle and the tendon, they're so weak that everything collapses when you're breathing in, right? And then with the way of airflow, from very simple mechanics, is wherever a floppy structure is, wherever the most flow is where it's going to collapse most. So if you've got floppy structures above your vocal cords, you're going to have a problem when you breathe in. Does that make sense? Yeah, right. If we take tracheomalacia. Tracheomalacia is, now here we're looking at the air. This is the same thing where a child's feet are again on the other side of the computer, or the screen. Here we're looking at child's airway. The food pipe is back here. Here's the tongue. Here's the right vocal cord and the left vocal cord. And this child is having trouble breathing out, not breathing in. And when we look here in the plays, and we're going through the vocal cords, and we can see what we normally would see is a big circle. Here's the muscle of the trachea coming up, and you just have a pinhole of an airway right here coming down. So all of that muscle is obstructing and coming down. So that child's going to have issues with breathing out. Does that make sense? And I guess I'll flip along and just say that go back and forth a little bit. If your child has an issue, I don't have a video of vocal cord paralysis, but if your child has vocal cord paralysis from a PDA ligation or from any kind of issue in terms of immobility, you're going to have your child have trouble breathing in and breathing out. Does that make sense? With laryngomalacia, which is when you're having trouble issues with breathing in, that's of all the procedures we like, that's the one that's probably the most fixable. There we go. Back and forth. With that, this is now we have a child who's intubated. This is a tube through the vocal cord. Here's the right and left vocal cord. Now you can see the vocal cord because everything's suspended. And we have little tiny little scissors where we can use to trim these tissues to make the breathing better. Just wonder, most kids with laryngomalacia don't need to be operated on. Most of the time with laryngomalacia, the kids will outgrow this. And the only time you would treat laryngomalacia is when the kids are having failure to thrive because they're having difficulty breathing. If they're having inspiratory stridor that's so bad that they just can't breathe, then these are kids that we can operate on and usually help. For tracheomalacia again, which is this floppiness of the airway, the take-home point here is that most the things that we see, like you were talking about on an endoscopy, what we see on a bronchoscopy, we don't treat a bronchoscopy, we treat a child. Right, so things that can look really floppy and really narrow and really terrible on endoscopy or bronchoscopy don't really matter to us so much. We really care much more what are the symptoms of the child. And this, here for us with tracheomalacia, we want to say to ourselves, here it looks like more of a back wall. This is more of a muscular problem for it causing tracheomalacia. But the question, if you think about the trachea as a pipe, either the pipe is compressing or there's something compressing the pipe. And that can be either one of those. And so we often ask ourselves, if it's the pipe itself that's compressing, it's either the cartilage is floppy, and then we call that intrinsic malacia, or the muscle is too broad or too floppy, and we call that intrinsic malacia, or that there's a blood vessel. This is just a picture of when we went through on a CAT scan or an MRI or what have you. This is a picture if your aorta, and this child has a double aorta, if that thing moves around. And sometimes we have blood vessels coming off the heart. That doesn't play. Either a big aorta, two aortas, the blood vessels coming off any of the heart that will put pressure on the trachea that can cause tracheomalacia. So it's super important in terms of these kids when they have those kind of issues in order to be able to know, is it intrinsic or extrinsic, and what's compressing in order to treat it. Finally, and again, then we'll get to more, I would just say, there are options nowadays for malacia, just to say we are using, we could talk about this. The first thing with tracheomalacia is just simple observation. Sometimes with tracheomalacia, if it's you're having issues at night, you'll think about CPAP or positive pressure in different areas. If you're having issues night and day with tracheomalacia, really symptomatic, you may think about tracheostomy with or without a cuff, and we could talk about all of this in the questions. We are now, in order to avoid trachs in some of these kids, discrete who have malacia, we are using bioresorbable stents in order to stent open the airway and allow this to solidify over time. And in very carefully crafted kids, these can either let the trachs come out or they can prevent them in the same place. And then with vocal cord paralysis, because some of the PDA ligations, and if your child has a vocal cord paralysis and you were saying it comes back, then that's wonderful. I would do the other, if it doesn't come back or you need something, a temporizer, this is the right and the left vocal cord, and this is a child who's had a left vocal cord immobility. And you can, if you just imagine the right side was plumper than the left side, but once the nerve is injured for a long enough period of time, the muscle will become weaker and thinner, and it won't move over to the midline. So we can take a little needle and inject basically a pumper, something to move that, to medialize that vocal cord over, and to move it over. The first substance that we used was Teflon. Teflon we know for pots. It just like it's non-stick. You don't use Teflon anymore because it moves from the vocal cord all over the body. So we use other substances, but there is the important thing about injections is they work for about a year and then they go away. So they're good temporizers to show if there's an issue, but then afterwards we can think of more. This is a Gore-Tex-like substance, where it is if an injection has worked, then we can use what's called cardiac Gore-Tex and push the vocal cord over permanently to restore voice and breathing. And the last thing that we're doing more and more these days is borrowing a nerve that isn't injured and implanting it into the nerve that is injured to do nerve anastomosis procedures. And those have been, what we used right there in terms of is we use what's called an evoked EMG in the operating room, where we're stimulating the vagus nerve, which is the nerve that's coming down to give the recurrent nerve up, and we're stimulating it above the point where we think there's been an injury. Maybe it's down where a PDA has been ligated, or maybe not. And then we're recording up at the larynx itself to see what do we actually have a conduit for which we can do a nerve anastomosis procedure or not. And this is just to say we have, in a situation where we get a really nice motor unit action potential intraoperatively, we'll do a nerve anastomosis procedure, and we feel like we get very good results, and this is predictive for us. If, on the other hand, we get a very flat tracing or with not much of a latency, this will push us away and to say, well, maybe we shouldn't do a nerve anastomosis procedure, and maybe we should do a medialization procedure itself. So we've got a lot of different tools that can help with regards to reinnervating or moving vocal cords over. So those are, I think, the three technique airway issues. And maybe I'll open it up for questions in terms of airway questions. Questions? Yeah.
You said you use a stent, got food or something trying to get down your esophagus, if you will.
So the question is how do you prevent issues from the stent? And the issue with regards to the stent is when we do place these stents, this is what a stent, a bioresorbable stent looks like. It's on the outside of the airway, and usually we put it on the outside of the food pipe. So this is the child's chin is up here, their chest is here, their air pipe is here, and in this child, it's the trachea or the cartilage, which has been floppy, and we put it on the we put that, since we're putting it on the outside, not the inside, right? Right, it's
Moving out.
yes, it's basically, and if we used to use internal stents, and that's where you have most of your complications. We've switched to external stents for the very reason that you're talking about, because it doesn't give us issues.
Thank you so much, Christopher.
For coming and for.
There's one question from the Zoom contributors, people online. About the question is, if I have white matter but I didn't have a stroke and I'm becoming an adult, does it mean that my risk of stroke is now lower? I would say it all depends on what you have in your aorta. Okay. There are some people that require valve replacements, and we do have patients with ACA2 that while they had to go off anticoagulation or on anticoagulation, when you get the valve replacement, you need to be on blood thinners and not aspirin, that's much higher. And if you have to get anything, like a colonoscopy and endoscopy, you have to stop them. And in those periods is when we see an increased risk of clots forming in the valve and coming into the brain. But that happens for anybody that has a valve replacement, not just ACA2. And in ACA2, what complicates things is the pipes are very thin, so smaller clots can get you into a lot of trouble. So overall, the risk of stroke, I would say if you pass your teenagerhood without a real stroke, not just the white matter that we were talking about, we think is lower if you could avoid getting a valve replacement, if you don't need a valve replacement. But that would depend on what is the problem with the aorta. So I hope that answers the question online. And with that, you have a question?
But with Sign, with his pretty graft, he was able to come off. He was just, and we're only on aspirin.
I hear that his valve is not replaced, no, Diana?
Not replaced, it's just.
Yeah, exactly. So there are kids that, and this is what the cardiovascular surgeons try to do, is not have to replace the valve, but it all depends on what the root and the valve itself is doing. If the valve is insufficient because it has gotten disrupted, that is a different story.
And you have
To do what you have to do.
Often the surgeon has to go in and actually look at the valve before he can make that decision, and that's what they'll tell you at the time of the operation. We think we can spare it based on the CT, but we need to look at the valve. And just one last comment. So for the last 34 years, the standard operation was to replace the aorta and go ahead and replace the aortic valve, because you had to remove all the diseased aorta, and they hadn't figured out technically how to leave a normal valve in place. So they've only been doing this procedure about 10, 15 years. The old procedure where they took the valve out and put the graft in with a mechanical valve, that we know that lasts a lifetime. We don't know how long these valve sparing procedures will last, and we're trying to get that data
From all the other.
from all the
Not just the ACA2, so for everybody that is the replacement. So I am gonna pass the microphone to